It's that little Chico Pitbull, Mr. 305, but I said Mr. Worldwide, and you already know what it is. Listen to my new podcast, From Negative to Positive. Subscribe today. Now, part of the things that we're doing over here at Negative to Positive is encouraging people to change their lives, change the things that are within their power. I want to thank our good friends at KFC for helping me bring this to you. Feed your whole crew with KFC. Let's go. I can get the KFC bucket of chicken, and you know, that's fire. Now, Babu, you know that you could get that mac and cheese, that mashed potato, gravy, those biscuits. Now, that's trouble right there. That is fire right there. You know, on Negative to Positive, we always talking about striving and achievement, and the Colonel Sanders story is a story that inspired me since I was 10 years old. Look how life comes full circle. Now I'm talking about Colonel Sanders and Kentucky Fried Chicken and how much I love it. Listen to my new podcast, From Negative to Positive. Check out the vodcast. Subscribe today. Apple Podcast, Podcast One, Spotify.
Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, and I'm sitting here on a Wednesday lunchtime, as a matter of fact, with Dr. Millicent Ravello. We've taken a break from our patients for a moment to knock out a couple podcasts.
That's right. We got to squeeze it in where we can.
That's right. Today we're going to be talking about who is not a candidate for a mastoplexy.
Who is not a candidate?
It's like the Borat not joke. Who's not a candidate.
Because this comes up so frequently.
This patient is not a candidate for a mastoplexy.
I'm gonna record you saying that and just play it to my patients. I'm like,
you're a candidate for mastoplexy. Not. You can use that one?
Yes, that's a good one,
Want
too.
to give you a few more? No.
But seriously.
It does come up.
It does come up.
Why?
And because I get frustrated. I want my post-ops to look amazing, and I want my breasts that I do to look beautiful. And I get so sad. Like, I literally get sad. I get sad when I do mastopexies on patients and their breasts don't look beautiful. And I get frustrated because there are patients that are great candidates for mastopexies and there are patients that are not. And when I do a mastopexy on a patient that's not a great candidate, I don't get a great result, and that makes me sad.
I don't want you to be sad.
I know.
Your patients don't want you to be sad. They want to do well for you. They want you to be proud of them. I know they do. They want you.
It's not really about them. It's about me. Joking. Totally joking. But I get it. But in the sense that it's true. You do want your plastic surgeon to be happy because that means that they've done a good job for you.
Well, let's start at the beginning then. Mastopexy is an operation for lifting the breast and putting
I'm going to stop you right there. It is not a breast lift.
It's a nipple areolar complex lift. With for me, it's moving the breast up the chest wall. I do some stuff with that.
Yeah, you can. But I think that's the first distinction that has to be made is that it's not really a breast lift in the sense that many patients want it to be.
They do. They want the breast to go up the chest wall. They come in
and they take their hands and they take it around their breast and they push it all the way up and they say, "This is what I want. I want this."
Well, you'll need an anti-gravity gun because that's not happening.
It's not happening.
No. But you can make the breast look beautiful.
Yes.
So
in the right patient.
Okay. So back to that. The ways that we can lift the nipple areolar complex and make the breast look more youthful and less droopy and saggy and sad is through a periareolar mastopexy with a cut around the nipple areolar complex, which can lift the nipple areolar complex a bit.
A few centimeters.
Yeah, not a lot. You can do a vertical where you do a periareolar incision with a vertical component down the front of the breast, underneath, going from the areolar complex to the inframammary fold.
Like a lollipop.
Where the breast meets the chest wall, like a lollipop. Or you can do a full-on anchor scar with around the areola, down in front, and then in the inframammary fold. That is the most gold standard. You're going to get a lift of the nipple areolar complex with that approach every time. Periareolars are very unsatisfying to me, but a lot of people want them because they don't need a whole lot of lifting and they don't want the scar down the front of the breast.
Right. And we are going to segue into a little bit of